kind of hard to follow Quill and the robot, but I'll do my best. So chronic subdural hemorrhage has not traditionally been something in the neurointerventional world, but it's a very common disease, soon to be the most common neurosurgical disease as our population age. And essentially, what we see, and you've all seen these cases too, is elderly patients with hypodense or isodense fluid that accumulates in the space under the dura with pseudomembranes, as you can see here. It is a major public health problem. It's a sentinel health event and a reversible cause of dementia in a world where there are a lot of unreversible causes of dementia. And conventional management at the moment is not something that's well studied or well proven. It's estimated to be at about 15 cases per 100,000 person, and both the aging of the population and the increasing prevalence of antiplatelet and anticoagulation drugs are increasing that incidence. By 2030, it's estimated that we're going to see about 60,000 cases of chronic subdural hemorrhage in the United States per year. The interesting thing is there hasn't been, in my opinion, enough work on what the actual physiology is. Initially, of course, we think there's a bleed. We certainly see acute subdural hemorrhages. But what happens after that bleed is that there's a thickening of the dural layer and a hypervascular ingrowth of neocapillaries with arterioles. These capillaries don't have normal walls. They're not normal capillaries. They're very leaky. And what happens is you end up with a constant exudative leakage of fluid through these neovascularized capillaries in these subdural membranes. And so what it appears is happening is you're getting a positive feedback cycle where the membrane line cavity continues to leak fluid, and that fluid leakage is irritative and causes continued membrane development and inflammatory activation. So what happens is we overwhelm the system. The veins can't mobilize the fluid fast enough, and the inflammation causes the fluid to continue to be leaked. As a surgeon, I've certainly operated on these and had to go back and reoperate. You can drain the fluid, but not fix the problem. So what we do typically is sometimes observe the patients. They don't typically get better on their own once they get into this cycle, but if it's a small amount of fluid, they can get better on their own. Or more often, we operate. There are different operations that we do. You can do a full craniotomy and strip or pull out these neovascular membranes. Unfortunately, sometimes that results in more bleeding. Or you can do burr holes. Typically, surgeons will do 2 burr holes and irrigate through them, placing a drain. There's a recent paper that says a drain in the subgaleal space over the burr hole is more effective than a drain in the subdural space. Or there are minimally invasive systems that you can use in the ICU. The SEPS is one of them. All of these procedures require taking an elderly patient, sometimes stopping their medications, and then often, in an elderly frail patient, you've got them down flat in the ICU for a period of time afterwards. And so there's a high rate of recurrence. It can be difficult to manage them. Often in our field, we'd love to be able to have blood clot in one part in the body, but not in another part of the body, and this is one of the places where we get caught. So is there another way? There's limited data on observation versus surgery, and in-hospital mortality and home mortality is high. So if we think about the vascularity, this is a vascular disease that affects our elderly population and affects neurocognitive function and quality of life. And so is there a strategy endovascularly? If we stop this, can we favor reabsorption rather than favor continued leaking? So there's some work already in the literature. The Band paper shows both preoperative embolization and SOL treatment has some success using a historical control group. Their primary outcome was treatment failure through 6 months, and they used surgical rescue. They did have statistically significant results using a historical control. A lot of people have used PVA. Jared Knopfman's published on this. We tend to believe that a liquid embolic with a low viscosity might be better. Distal penetration into these leaky capillary beds, I think, is where it's at in terms of where we think the physiology would work. And furthermore, if you're not careful, as neurointerventionalists know, at the petrosal branch, you can get the vasa nervorum and cause cranial neuropathies, which we really need to avoid. So this is an angiogram of a distal catheter in a subdural membrane. That's what it looks like. That's the pathology. You can see that it's irregular. You can see that there's this cotton wool type appearance. And if you can get a microcatheter out there, this is what it looks like when you inject a liquid embolic into the pathologic chronic subdural membrane. So as you can see, you're getting collateralization into other branches, and you're really affecting the membrane itself, ideally in a way that's safe and not threatening any of our neurophysiology. It can be difficult in an elderly patient to get this far out, but the reward, if you can get that far out, is really this phenomenal blockade of these leaky neocapillaries within the subdural membranes. So this is my preferred way of treating it. I have some colleagues for whom this is a preferred way of treating it. It's fast, it's permanent, it's safe, and this is old. We're now at over 70 patients with no significant neurologic complications, and we have now had a couple that have needed surgical rescue. We've not seen any deterioration, and we've seen some really impressive improvements. So this was my first patient, not a particularly old patient, but he really didn't want burr holes. At 12 weeks, he had a complete resolution. This particular individual had a neurologic improvement at 4 or 5 days, went from a solid pronator drift, falling to one side, to better very quickly. Here's another example of an isodense mixed intensity subdural. At 4 months, complete resolution. Another example where you see the mass effect resolve in 3 weeks. The CT on the right was read as normal by the radiologist. It isn't. But it is pretty amazing to take somebody with a neurologic deficit, make them better in a couple of days, and have a CT that's close to normal at 3 weeks. So I think this is a treatment that has a tremendous potential impact, and we've announced a randomized controlled trial that was rapidly followed by several groups that are doing similar trials, which I think is great. There are trials planned using SQUID, using Onyx, using PVA, using FIL, and I think there may be one with NBCA as well. While many people in the room are already treating, and we can, I think a multi-center randomized controlled trial, or in this case maybe several, would really be the way to investigate this in a responsible manner. So our trial is a bifurcated trial with 1-to-1 randomization, either pre-surgical embolization for the people that the treating team feels really need to be treated, or embolization in lieu of surgery in those who have less mass effect and neurologic compromise. Here's the randomization schema, what that looks like, and our primary endpoints in terms of efficacy and safety. They're sensible. Secondary endpoints in our trial includes a lot of other things, including neuropsychology, which I'm excited about. Even if the intervention fails, we're going to learn a lot studying these patients in terms of neuropsychology. And we're, at the moment, planning to randomize up to 276 patients within this trial, STEM. So basically, I think the idea is straightforward, and I'm excited that this is potentially a disease state where we could help a lot of people avoid craniotomy and avoid needing to be off of concurrent medications and improve dementia. Thank you very much.